The importance of the dentin is that during clinical work, when you treat the patient, when you form a cavity, for example, when you prepare a cavity, you will prepare first usually the enamel and after the dentin. When the dentin is exposed, the dentin itself is a sensitive tissue, it is sensitive for the patient. The patient may have some complaints, and you should know the physiology of the dentin, the clinical connections of the dentin, because the dentin itself is a living tissue. And the dentin is the main part of the tooth. Of course, it is a connective tissue, and it is a type of extracellular matrix. And this dentin is found in the ground part and in the root part as well. And we have different characteristics of the dentin, different types of the dentin in connection with the formation of the dentin and location of the dentin. We have different forms of the dentin. So this dentin is important clinically. Even the pathology is important. We have caries. The caries is the main dental disorders affecting the hard tissues, the dentin, of course, and the enamel, and the cementum. And we should know the diagnostic things of the dentin when you investigate the dentin sensitivity, and with different physical method, with different physical examination, you will examine the dentin, the color, the structure of the dentin is changed when it is affected by caries, but even the X-ray manifestation of the dentin, so Röntgen or X-ray manifestation of the dentin is important because when you take an X-ray, you will see the changes of the dentin when we have pathological processes inside the dentin and inside our teeth. And you should know, of course, the chemical composition and characteristics of the dentin. It is inorganic mainly, but we have organic component which is mainly collagen, but we have 10% non-collagen proteins, for example, phosphoproteins. Dentin type phosphoproteins are very special and very important, connecting to the formation of the dentin and calcification of the dentin. And we have of course, inorganic component with crystals, amorphous and hydroxyl apatite crystals, mainly hydroxyl apatite crystals. These are the most well-formed crystals of the calcium phosphate. So the calcium phosphate crystals, when it is well matured and when it is well developed, it is formed in hydroxyl apatite form. We have different forms of crystals, but this hydroxyl apatite, which is inside the dentin and in the enamel itself, it is the most mineralized and most mature type of crystals. And as I mentioned, you mainly collagen is in the organic component, but the organic component is only 18%, and we have the collagen 1, 3, and 5. Mainly collagen 1 is the predominant collagen and of course protein type of the dentin, and we have water content of the dentin. So this chemical composition will affect the clinical and aesthetic and physical characteristics of the dentin. Of course, in dentistry, the anatomy and the aesthetics and function, these are the most important things. And in connection with the dentin, again, the anatomy and the aesthetic. The aesthetic is important because it is yellowish a little bit. So when you have very thin enamel layer, the underlying dentin will overshadow the enamel aesthetic, and the whole tooth appearance will be a little bit darker, more yellowish and less aesthetic because of this dentin color. So the dentin color is less aesthetic, and maybe it is less wanted when you make filling, for example. You should consider the dentin structure and the dentin color, and when you place a filling, sometimes you have to cover this yellowish structure, this yellowish shade of the dentin, because this underlying yellowish color will make your aesthetic feeling unaesthetic in appearance. And of course, the hardness of the dentin is important. Again, it is less hard than enamel and the cementum, but it is very important that it is more resilient. The dentin is softer, but the resiliency of the dentin and is higher, so it is cushioning the overlying enamel. So when the dentin contains less water, after root canal treatment. After root canal treatment, the water is disappearing for the dentin, and the hardness of the dentin is increasing. And even with aging, the aged dentin in old people, the hardness of the dentin is increasing with age. And when the dentin is harder, the cushioning effect to prevent the enamel from breakage, is less effective, and those teeth will break, the enamel will break more easily because root canal treatment, because of aged dentin and aged teeth. And the inner part of the dentin is softer, and as I mentioned you, with aging, the hardness is increasing, mainly with the peritubular dentin. We have different types of dentin, we will discuss later, and this peritubular dentin is forming, producing with the age of the person. And the elasticity is important to prevent any breakage of the enamel, or fragility is decreased of the enamel when the elastic dentin is good in structure and contains the appropriate amount of water. And the permeability of the dentin, tubular structure, permeable, even bacteria can penetrate through the dentin. And it's important because when it is affected with caries, the caries and contains a lot of bacteria, the material and the bacteria can penetrate, and the toxins of the bacteria can infect the part tissue, and pulpitis can develop. Sometimes even the dentin is there is an intact layer separating from the caries to the pulp. So the permeability is important, and when you have caries, some other dentin, so-called tertiary dentin is formed. And this tertiary dentin permeability is less than the normal dentin permeability. So it is very important that in this case, when you have caries, the dentin itself is defending the part tissue with tertiary dentin production. This tertiary dentin is an extra layer, extra defensive layer for the part, because a new layer is formed to prevent the part from the caries, but it is less permeable because the tubular structure is less regular in this dentin, and the tubular diameter is smaller in the tertiary dentin. And not just pathological caries situation, but in aged people, again, the diameter is decreasing with the peritubular dentin formation. So we have different types of the dentin. As I mentioned, you can classify the dentin according to the formation and according to the location. You can see here the formation of the dentin. Mental dentin is the first form dentin. Of course, this is the first product of the odontoblastic layer. As you know, the pre-odontoblastic cells from the dental papilla is activated by the ameloblasts and the ameloblast basal layer membrane, and And after this, the first from dentin, which is less mineralized and the more without amorphous. It is an amorphous type of dentin. This is the mental dentin. When the mental dentin, it is a very thin layer, some micrometers. Then the mental dentin is formed. Primary dentin is starting. In case of primary dentin, we have tubular structures because in this phase, the odontoblastic cells have processes, processes. When you have odontoblastic processes, not mental dentin, but the primary dentin is formed. And we have predentin. This predentin is, less mature dentin, like we have osteoid bone and osteoid,
Not mineralized.
Non-mineralized, and it is a non-mineralized form of dentin. This is the predentin, and secondary dentin is formed after the eruption. Tooth eruption is completed. After the tooth eruption is completed and the apical area, the physiological apex, is restricted of the tooth. So after eruption, it takes about 1.5 from 3 years to 3 years to restrict the apical foramen. When the apical foramen is restricted, the perfusion through the vessels of the pulp and the odontoblastic cells is decreased, and not the secondary, the well-organized primary dentin, but the secondary dentin is formed. So after the root apex is restricted, the secondary dentin is formed. But this predentin is always between the part, between the outer layer of the pulp, which is the odontoblastic cells, between the odontoblastic cells and primary dentin, odontoblastic cells and secondary dentin, and even odontoblastic cells and tertiary dentin. Predentin is always there, always there, because it is a non-mineralized dentin form. And we have two different types of tertiary dentin, the so-called reactionary and reparative dentin. It is forming in different stimulus, after different stimulus, even pathological condition, after pathological condition. So you can see here the location, according to the location of the different dentin types. The primary dentin is the most abundant. You cannot see macroscopically, of course, the mental dentin, but microscopically, because it is very thin, only some micrometers. And the secondary dentin, when the tooth is healthy, it is indifferently from the age of the person and the tooth. The secondary dentin is always formed, of course, and restricting the pulp chamber and cavity system of the tooth. And but when you have some problem, for example, fracture, caries, accretion, abrasion, the tertiary dentin is forming to protect the pulpal tissue, and the tertiary dentin is formed in a localized way, because the secondary dentin is generalized dentin type, so all around the pulp chamber and the pulp cavity system, but the tertiary dentin is only localized, so near the stimulus. Near the stimulus could be caries or accretion. As I mentioned, it is only local. And about the mental dentin, you can see here, as I mentioned, near the dentinoenamel junction, it is some micrometer, and this is a very important component from cork fibers in it. And of course, it is an amorphous structure without tubular structure. The tubuli and are not found in dentin, which is less mineralized. Because the tubular structure is here when the dentin is well mineralized. But in the this dentin, the ventral dentin, no tubular structure, but so-called phone core fibers. These phone core fibers are collagen fibers perpendicular to the surface and to the dentino-enamel junction, and very rough fibers, and between them there are amorphous calcium phosphate crystals, apatite crystals, amorphous apatite crystals, and after this production is finished, the mental dentin production, which is less mineralized, new dentin, very regular, very mineralized dentin, which is the first primary dentin is formed. So you can see here the enamel, the wavy or scalping surface, dentino-enamel junction, wavy, bordered between the enamel and the dentin, and this uppermost part of the dentin, outermost part of the dentin, which is pale because less mineralized in this section, and it is amorphous. You can see here the structure, tubular structure of the dentin inside the primary dentin, and this is the pre-dentin. Okay, the pre-dentin. Yes, the primary dentin, tubular, even in the pre-dentin, but here you cannot see because amorphous, the mental dentin. And the classification, mineralization of the dentin is very important. I mentioned you that three odontoblastic layers from the dental papilla. The dental papilla in the late Bell stage, developmental stage, is depressing the enamel organ. The enamel organ is depressed, and the inner layer of the enamel organ is formed by the ameloblasts. And under the ameloblasts, there are basal membrane, and the structure of the basal membrane and the enamel producing cells, ameloblastic cells, is initiating or regulating the outermost cell layer of the dental papilla to differentiate into odontoblastic cells. First, three odontoblasts, and after odontoblasts, when you have these fibers, the odontoblasts are formed. And first, there are so-called special vesicular formation of the crystals, vesicular. We have different classification in our body. For example, in bones, we have heterogeneous mineralization. So it means we need some core molecules onto the core molecule surface, some minerals, calcium phosphate crystals, we are depositing. This is the heterogene mineralization. But here in mental dentin, we have a special mineralization type with mineralization vesicles. Vesiculars are little balls, membrane bordered balls containing calcium phosphate crystals in it. So these vesicles are secreted by the odontoblastic cells, mainly the processes of odontoblastic cells. These vesicles part of coming from the membrane of the odontoblastic cells and containing a lot of crystals, So these vesicles are produced by the odontoblastic cells, and these odontoblastic cells will, after it is produced, in the extracellular area, in the dentin, later dentin area, these balls or vesicles will rupture up, and the content, the calcium phosphate contents pouring into the extracellular matrix, and these crystals will be the source of the mineralization, because after this they will depositing onto the surface of the macromolecules of the extracellular area, mainly, of course, core fibers, from core fibers, large collagen fibers. And so collagen network, I mentioned you these fibers, extracellular fibers, and onto the collagen surface, these crystals will be depositing, and the calcification is starting, and the focal, first the core or focal calcification is formed, and after this is enlarging and fusing together, and continuous calcification is forming, with that amorphous structure I mentioned you in connection with the histological section, previously showed histological section of the mental dentin. So there are other molecules, because the mineralization shouldn't be unorganized, because when the mineralization is unorganized, every cell around it will die, of course, because of the mineralization. This mineralization could die the cell function, of course, when it is unwanted. When it is unwanted, for example, in sclerosis, in sclerosis, arteriosclerosis, of course, the mineralization is an unwanted process. So the mineralization should be regular. And there are some molecules which are interfering, and there are some molecules which are advancing the mineralization. And the fine tuning of this against and for molecules will resulted in well-regularized mineralization. So there are supporters, and there are there are molecules against the mineralization, collagen and phosphoproteins, phosphorin, for example, and for the mineralization, against the mineralization, nucleotides, proteoglycans. These are large molecules, and connecting a lot of water, and of course the water and can prevent the mineralization. And pyrophosphate. This pyrophosphate is important or interesting because when you see the content of some toothpastes, these pyrophosphates containing the anti-tartar phosphate. So anti-tartar because the tartar means, of course, deposits, hard deposits under tooth or tooth surface. This means pardon?
Can you repeat again?
Anti-tartar, the brown one.
This means stones, dental stones, stones or dental stones,
Black?
No, not black, mineralized plaque.
It's a brown color.
Calculus in Latin, calculus. So anti-tartar means anti-calculus toothpaste, Anti-calculus toothpaste contains regularly this pyrophosphate content. You can check in the mineral content, in the contents of the toothpaste. So it is important. And it is very important that in dentin, so-called globular mineralization is occurring. Globular, Globules means spheres, balls, so globular. In small core, larger balls, larger globules is forming, and at the end, these globules are fusing together. So in the dentin, globular, maybe you know this interglobular dentin. Interglobular dentin is located in the outer part of the dentin, where the mineralization is not complete, and sometimes you can see foci or some areas without mineralization, and this bat wing structure between balls. So globular mineralization. And I mentioned you that different molecules we have in detail. We have phosphoproteins, for example, osteopontin for the mineralization, promoting the mineralization, and osteonectin is one part promoting, one part decreasing the mineralization for and against the mineralization. But it is important that this osteonectin will have the deposition of the calcium and phosphate onto the collagen surface. And as I mentioned you, this toothpaste content, the pyrophosphate, is absolutely against. So no question that pyrophosphate is against the mineralization. And we have a special protein. It is a special enamel derivate protein and ameloblastin covering the root surface, root surface coming from the root sheath. And this special protein is important for us because it is used even in the clinical practice, in the surgery, in regenerative surgery, in regenerative endogain, maybe you know this, endogain. It is a special molecule will help the mineralization, and when you do periosurgery or bone regenerative surgery, you will place simply this ameloblastin or endogain in brand name, onto the surgical site, So when you have periodontal bone dissection, periodontal bone problem, you will cut off, remove the gingiva from the tooth and clean the wound, the bone and the tooth surface, and simply you place this material, ameloblastin, endogain, to the site, and this will help the regeneration or regenerative process. New bone formation is promoted by this ameloblastin. So the ameloblastin layer, it is an amorphous protein layer covering the root, will help the mineralization again. Will help the mineralization, for the mineralization. But it is not just theoretical, but it is used in the clinical practice. Even nowadays in surgery, this ameloblastin is used as endogain. You can find in the internet. And the mineralization first, less complex mineralized forms, blueshite, maybe you know this, so less complex, and after hydroxyapatite crystals will be formed. Okay, so less organized crystals, and from the less organized to the well organized, but at the end, all the crystals will be hydroxyapatite crystals. Okay, hydroxyapatite crystals. In the tooth, we have different mineralization. So we have the vesicular mineralization only in the beginning, in the mental dentin. We have vesicular. I mentioned these vesicles are cut off from the processes of the odontoblasts and tearing up in the extracellular matrix, pouring the content, calcium phosphate and mineralized content into the extracellular space. And there will be the globular mineralization in some areas. These globulars, these balls, are named as calcospheride crystals in the dentin, calcospheride crystals, and these are occurring in areas, for example, the interglobular, in the interglobular dentin. And we have the linear mineralization. This is the most popular mineralization in the body, in bones and in dentin as well. But we have these two types as well, but the linear mineralization is the most important, of course, but these are important, but at the beginning. And here we have a mineralization front, and in this mineralization front, below this mineralization front, that is the p1dentin, for example, and above the mineralization front, there is the mineralized dentin, primary, secondary, or tertiary dentin. So this is the meaning of the heterogeneous or linear mineralization. We need a mineralization front here, bordered mineralization, p1dentin and mineralized dentin. And of course, sometimes we have mixed mineralization, globular and linear, but this matrix vesicle mineralization is very, very unique in the ventral dentin, just in the ventral dentin node as well. So, the mineralization, or here the dentinogenesis, first we need a matrix, scaffold, or scaffold for the mineralization, and these collagenous fibers and even ground substances will serve as matrix for the mineralization, and hydroxyl apatite crystals later we are depositing on the surface of these matrix components or molecules or scaffold molecules. And I have mentioned you this earlier, that first crushite, for example, is formed, and less organized calcium phosphate crystals, and later well-developed hydroxyl apatite is forming. So this is the normal way of mineralization in the dentin. You have these calcospheric crystals, globular mineralization. So in some areas in the p1dentin and dentin, so that eudentin, eudentin means mature dentin, mineralized dentin. P1dentin is non-mineralized dentin, of course. This eudentin could be primary dentin, secondary dentin, tertiary dentin. It just means that it is mineralized, okay? So mature dentin, and you can see here this in this border, in this area, the crystals, the calcospheric crystals, globular mineralization, and after a globule is formed, and between the globules there will be first non-mineralized areas, even some areas there will be so-called batwing structure, as in the interglobular dentin, but later these globules will fusing together, and continuous and mineralization is seen, okay? These are the vesicular, membrane-bordered vesicles from the membrane of the odontoblastic processes containing hydroxylapatite crystals. These crystals, after the eruption of the membrane or tearing up of the membrane, these crystals will pouring into the content of the matrix vesicles, will pouring into the extracellular matrix, and this will be the source of the calcium and phosphate, which are elementary for the mineralization. And there are stages of crystallization or mineralization. First, after we have a scaffold, or after we have a centered for the core molecule for the mineralization, the nucleation is starting. Nucleation means crystal cores are forming, and after this, it is growing, of course. So these are stages, two stages, the initial stage and the growing stage, or these are just theoretical thing. And you can see here apatite crystals, and these apatite crystals are forming around the preformed collagen network. So the collagen network is very important, and after collagen network is formed, the crystals are depositing between the network. In the dentin, the collagen network is very, very irregular. In the cementum and even in the bone, in the cementum it is well regularized, but in the bone it is less regularized, but in the dentin it is absolutely irregular. The collagen network is absolutely irregular. And we have this collagen network only in intertubular dentin. Okay, intertubular dentin, but because in peritubular dentin there is no collagen network. And you can see here this globular corpus ferrite balls mineralization, and when you have the mineralized areas, there will be the tubular structure. Okay, tubular structure. These are this is a picture from the interglobular area, battling structures, interglobular area, and when you have the non-mineralized dentin, there are no, of course, tubular structure in the dentin, no tubular structure, and different, in different levels, we have the front of mineralization, and different molecules are secreting by the odontoblastic cells into the extracellular space. Phosphatases, enzymes, and other proteins and proteoglycans, collagen are important. As I mentioned, proteoglycans are large molecules against the mineralization because of the large water content, and these are negative charging cells, and the calcium will be attracted to these cells, and these proteoglycans will prevent the calcium to depositing onto the surface of the collagen network. Okay, so these are against the but the collagen itself is the most accepted, and it is a well accepted core molecule for the mineralization. And there are two secretion levels. First, in the first area, the collagen and proteoglycans is secreting near the body of the odontoblastic cells, but near the mineralization front, the phosphoproteins are producing which are necessary for the mineralization. So this is a two phases or two stages of theory, mineralization theory. So near the cell body, collagen and proteoglycans are formed, and near the away from the cell body, phosphoproteins. As you know, these alkaline molecules are very important for the mineralization. And the calcium flow and the calcium supply of the mineralization is important. It is said it is actively transported by the odontoblastic cells, odontoblastic cells to the cells, and some part of the calcium between cells. So the calcium from the, because under odontoblastic layer there is a well supplied with vessel and blood, well supplied area, and from this area the calcium is passed or transported actively, mainly by the odontoblastic cells to the mineralization front. So these calcium will take on, and by the odontoblastic cells inside we have the Golgi and the mitochondria containing a lot of calcium, and after the intertubular transport, the calcium is transported and passed into the other side of the cell to the mineralization front. And as I mentioned you, the area under, so the outer layer of the pulp contains vessels which are capillarity is relatively good and which are important for the mineralization. Okay, so next will be the, I mentioned you, we have here the seminar, okay? Maybe Dr. Kalentay will be here to read up the names, okay? He will be here. And